Good evening, everyone, and welcome to Animal Cancer Care Clinic's second session of our summer webinar series, How to Navigate Through the Cancer Diagnosis. I'm Dr. Stephanie Correa. I'm the founder and president of Animal Cancer Care Clinic, and I'm so pleased to be live with you guys this evening and to be moderating this event. So thank you for being here. Thank you for joining us and for taking your time to spend with us. And of course, Mark, thank you for making this happen, for providing this platform and all of the behind the scenes technical support. We really appreciate it. So last year, I decided to start this summer webinar series because I really wanted to bring us together as a community of veterinarians to be able to learn from each other and ask questions and just to celebrate being veterinarians and being this community. And for those of you who know me well, you know that I have been a part of this veterinary community for a very long time. I am a second generation veterinarian. My father, Dr. Jerry Shank, owned and operated a veterinary clinic in Fort Lauderdale, a small animal practice. I have literally done every job in a small animal practice. But I'll tell you what, it wasn't until I owned my own hospital that I understood why, when I was working for my dad, whenever I would go to pull a sheet of paper towel from the roll, he would say, "Hey, do you really need that whole sheet of paper towel? Why don't you just rip it in half and use half the sheet?" So thanks, Dad, because now that I own my own hospital, I get it. I get it. So since we opened ACCC, we have grown, metastasized, spread, whatever, to 8 locations throughout the state of Florida. And that growth really reflects the trust that you have in us to take care of your animal patients. And it reflects our commitment to touching as many patients with cancer in the state of Florida as we can. Cancer care, that's all we do. That's what we do. Our team, we work together diligently every day to provide hope. We give hope to your clients, to animal patients. And for us, hope is healing and optimism, patience with ourselves, patience with each other, patience with our clients, patience with our animal patients, and empathy. So hope for us, it's what we do every day. So thank you for trusting us to do that. Thank you for trusting us with the care of your clients and the care of your animal patients. And lastly, before we move on, remember that easiest, most efficient, quickest way to get an animal patient to us is to use our referral channel, cancercarereferral.com. And so it's easy. You go on, you log on, and you enter the client contact information and the patient information. And you can certainly have one of your vet techs or CSRs do this, enter the patient information, any notes that you want us to see about the case, and then attach the medical records. And then you send that to us as a very nice, complete package. And we get that information, and then we know exactly how to schedule that patient, whether it's with MedOnc or RadOnc or SurgeOnc, what location, what doctor you want them to see, and then we'll take care of everything. We will reach out to your client with a welcome letter, all the logistical information. We will call them and we will say, listen, your family veterinarian really wants Fluffy to see Dr. Soanes in this location for this, and we will get them all set up. So any questions about our referral channel, please call us, email us. We can walk you through it. It really does get those patients to us in a very expedient, efficient way. So moving on, I am so pleased to introduce my good friend and colleague for many years, Dr. Evan Soanes. Dr. Soanes always dreamed of living in Florida after visiting the state numerous times during his childhood. He's now allowed to feed his obsession with Disney World as a resident of Orlando. He enjoys watching the park's fireworks from his backyard every evening. That's so great, all right? So Dr. Soanes, he received his bachelor's degree in Doctor of Veterinary Medicine from Louisiana State University. He then completed an internship at Georgia Veterinary Specialists in Atlanta before completing his medical oncology residency while earning a master's degree in biomedical sciences at Auburn University. A board-certified medical oncologist, Dr. Soanes has been with ACC since 2012 and treats animal patients in our Central Florida offices in Melbourne and Orlando. So, Dr. Soanes, thank you for being here. We're so excited to hear what you have to say tonight. And everybody, please type in your questions. I'll be monitoring those questions, and we hope to get all of those answered at the completion of Dr. Soanes' lecture.
All right, thank you so much. I'm excited to be back again talking about my favorite cancer, lymphoma. I think it's just a really, really common cancer that we see all the time, and I really enjoy treating lymphoma patients. So I also like talking about lymphoma a lot. So just to start out, a little bit of commonality. Again, it's a really common cancer in dogs and cats. It affects animals of all ages. So we do see a few dogs less than 1 year. So 1.5 dogs out of 100,000 dogs with lymphoma will be less than a year old. And then most dogs are a little bit older, so 84 out of 100,000 between 10 and 11 years. We do, I think, see really young dogs periodically, and people are always shocked, but I think that's just the nature of this type of cancer. And lymphoma does make up anywhere between about 7 and 24% of all the canine cancers that we see. So it's just super common. We all know the breeds that are at risk: boxers, bull mastiffs, bassets, St. Bernards, those dogs. And then luckily I have dachshunds, so I'm always happy to say that dachshunds are at a decreased risk of developing lymphoma. And a really big question we get from clients all the time is what caused this cancer, because they are always worried about if they did something wrong or if there was something they could have done, or we see sometimes families that have multiple dogs with cancer, and do they need to move? Like, is there something going on in the house? And it's really, I think, largely unknown and probably multifactorial. In other words, there's a lot of things that contribute to the development of cancer. Sometimes genetic and environmental factors just mix together in the wrong way and lead to the development of cancer. We had the ACVIM conference a few weeks ago, and I was surprised that there were a lot of talks about the etiology of cancer and what's causing it and trying to figure that out. So hopefully we'll know a little bit more in the next few years about that. So diagnostics, we're gonna all see these typical patients, dogs that come in with enlarged lymph nodes all over, and the owners are worried because they feel these lumps all of a sudden. And so what are we gonna start with? Well, if the lymph nodes are enlarged, cytology is always the best place to start. It's the least expensive, it's the least invasive. You usually don't have to sedate the patient. You get the results pretty quickly. And cytology can give you a lot of information, like the yes or no lymphoma most of the time, but also more about the grade, which correlates with the size of the lymphocytes. So if the lymphocytes are small cells, then that's usually a low-grade lymphoma. If they're large cells, that's usually more of like a high-grade lymphoma. So cytology is still our preferred diagnostic. Histopathology from a biopsy is a little bit better, and I think still considered the gold standard diagnosis for lymphoma. It is more invasive and requires anesthesia because it's a brief surgical procedure, and you do get more information. So, for example, you can use immunohistochemistry, which we're going to talk about, to find out more about the type of the lymphoma. You can sometimes diagnose the indolent forms of lymphoma, for example, marginal zone and T-zone lymphoma. And a lot of times you do need to send it to a hematopathologist that kind of specializes in lymph nodes, but not always. A lot of pathologists can give you the information you need. So advanced diagnostics. Once we've made the diagnosis of lymphoma, what do we do to get more information? So there's several different ways that we can get more information about the lymphoma. The first is immunohistochemistry, and also a little bit immunocytochemistry. So those are done on the samples you take either from cytology or biopsy. Immunohistochemistry gives you the immunophenotype because we have different stains for B cells and T cells. So it can be helpful in giving that information. It also can diagnose indolent forms of lymphoma. So sometimes on the cytology, especially if it's a small cell lymphoma, you'll get a kind of an inconclusive result. So a good example is the dogs that you get back the lymph nodes and the lymph node cytology, and they call it lymphoid hyperplasia or reactive lymphoid hyperplasia. Then you have to think, well, what is it reacting to? Like, if there's nothing going on with the dog, why am I getting this result? And in some of those cases, it's indolent lymphoma, and immunohistochemistry can help in that diagnosis. And then it's helpful for the sort of rare types of cancer or lymphoma. So for example, in cats sometimes get Hodgkin's-like lymphoma. Most dogs and cats get non-Hodgkin's lymphoma. And Hodgkin's-like lymphoma is called a T-cell rich B-cell lymphoma. And really the only way to diagnose that is with immunohistochemistry on a histopathology sample. And this is an example of what that looks like. So the top two are just the typical, the top left is the entire lymph node. The top right is focused in on the lymphoma cells. And then the bottom two have the immunohistochemistry applied. So you can see that it's lighting up the brown cells. Two other advanced diagnostics that we use are PAR and flow cytometry. So these are relatively new tests that have kind of reached a point where they're widely available. So all of our big labs, Antec and IDEX, have these. We like to send ours directly to Colorado State University Immunology Lab. So there are lots of options now to run these tests. And I see all the time on the reports we get from the labs that they're recommending these tests more and more. So I wanted to take a little time to go over the difference between the two, and then kind of talk about when to use them and what they do. So PAR, or PCR for antigen receptor rearrangement, is actually evaluating the DNA of the cells. So it's looking at the DNA to look for clonality, because clonality is the hallmark of cancer. So in other words, all the lymphoma cells came from one bad lymphocyte in the first place. And if that's the case, then they all have the same DNA pattern. And so we want to look for that. The PAR test will also give you the immunophenotype, but that's about all that it tells us. So it tells us, is this lymphoma or not, and is it the B cell or the T cell lymphoma? The main benefit of PAR is that you can run it on pretty much any sample that you can extract DNA from. So for example, you can do it on cytology samples, on biopsy. If you have a flow cytometry, which we're going to talk about, that's all the cells have died and they're just kind of rotting away in the fridge, then you can usually still get enough DNA to run the PAR test. So that's the main benefit of that test. Flow cytometry is a little bit different. So flow cytometry is actually looking at the surface markers of the cells. So the cells have to still be alive, and they have to still be, they have to be in suspension, because we need them to be able to flow through the flow cytometer. It gives you a lot more information than PAR. So it gives you a yes or no lymphoma, gives you the immunophenotype, so B cell or T cell. And then there are a number of other prognostic markers that are helpful that the flow cytometry can give you that the PAR can't. So for example, the size of the cells, the level of MHC class 2, there's a number of CD markers that it can tell you more information about those cells. So it's a lot more information. It also is a lot faster than PAR. Usually the flow cytometries are coming back somewhere between about 2 and 5 days now, whereas the PAR generally takes 1 to 2 weeks. So it is the preferred. The biggest downside is that the cells have to be alive. So for example, if you send the cytology in, it's confirmed as lymphoma, and then you want to run flow cytometry, you need to get a new sample to send that in, because the cells need to be alive for the test to be valid. And the biggest thing is knowing what sample to take. So for example, in the example we just talked about, if you take a lymph node cytology, send it in, the cytology comes back as lymphoma, you want to run the PAR test, then you need to take the fresh sample from the same lymph node, or at least from the peripheral lymph nodes where the lymphoma is versus the blood. I've seen a few times where a cytology is done on the lymph nodes and then the flow cytometry is done on the blood. Well, the blood is probably going to not have lymphoma cells in it unless the dog has a high stage of lymphoma, and so that you may get a false negative and get no evidence of lymphoma, which would not be the case. So it's important to remember that with both of these tests, whatever, wherever those lymphoma cells are, that's the sample you need to use to send in that test. So a little bit more about flow cytometry, because I love this test so much. So the way that it works is the machine is called a flow cytometer. The cells have to be in suspension so that they can flow through the machine. It shines a laser on them and then measures how much scatter comes off of that laser and how much of the cell and how much of the laser actually goes straight through the cell. And then the machine can use that information to determine what type of cell that is. So it literally can count every cell that passes through the machine and then give you totals. So you're going to get a report that looks kind of like this. So this is what the report looks like from CSU, which is where we send our samples. And you do get a written paragraph that explains the results, but I think it's important to kind of know what they're looking for in those. So you can see along the left side, they list all the different markers that they're looking for. So T cell markers, B cell markers, monocytes, neutrophils, and then CD34 is a marker for acute disease. So like acute lymphoblastic leukemia, acute myelogenous leukemia would fall under that one. And then along the top, we have the size of the cells, so small cells, and then medium or large cells. So the majority of lymph node, so this particular report is from a normal lymph node. So the majority of the cells should be small, and you can see in this case 78% of them were small. And then some of them should be medium, large, 22%. So that's normal. And then in a normal lymph node, you should have about half B cells and about half T cells. So if you look in the small cell column and go down to the pan T cell markers, you can see they're right at 50%. And then the B cells are right at 45%. So that's pretty much half and half. And that's exactly what we want to see in a normal lymph node. In a dog with lymphoma, the size of the lymphocytes is going to flip to large cells. So you can see in this case, there were only 10% small cells along the top of the page, and then 90% medium or large cells. So most of those cells are large. And then if you go down and look at the type of cells that are present, in the large cell column, 98% of those were B cells. So that would make this a B cell lymphoma. And then if we look way at the bottom, we have two prognostic markers for B cell lymphoma. One is the size of the cells. These are medium size, and that's positive. And then they have high expression of class 2 MHC, and that's also a positive marker. So this particular report is probably the most common one that we see. So it's diffuse large B cell lymphoma. The cells are medium size on flow cytometry, which is good, and they have high MHC class 2, which is good. And we see this one all the time. This is an example of a case where we have, again, large cell lymphoma. You can see 84% of those cells are large. Most of them are T cells in this case. So you can see pan T cell markers, 96% and 2% have those. And then B cells, only 1% are B cells. So this is going to be a T cell lymphoma. And then this one is actually from T-zone lymphoma. So you can see T-zone lymphoma is one of the indolent forms of lymphoma. So this is one that's really common when you get the cytology back that says, oh, this is lymphoid hyperplasia, but you have no reason to think the dog should have lymphoid hyperplasia. In a lot of those cases, they probably have some sort of lymphoma like this T-zone lymphoma. So you can see in this case, most of the cells are small, 98%, which is actually too many, because if you remember, the normal lymphocyte only had about 80% small cells. So this is an increased number of small cells. And most of those are T cells, 91%. And then if you go way down to the bottom, those cells have lost expression of CD45. So you can see they're CD5 positive, but CD45 negative. And that is a marker for T-zone lymphoma. Interestingly, we've been finding more and more dogs that have two types of lymphoma. So they have that typical diffuse large B-cell lymphoma that we talked about a few minutes ago, the most common one. And then they also have a subset of CD45 negative small T cells, which would be consistent with T-zone lymphoma. I'm starting to see that more and more, and I think we would not have picked that up previously if we weren't doing so many flow cytometries. And the reason that that is important is because those dogs may go into remission for their B-cell lymphoma with the typical chemotherapy protocol, but the lymph nodes may not go all the way down because the T-zone lymphoma is not responding the same way, and so it can be a little bit harder to interpret the results of your chemotherapy. So it's good to know that information in those patients. The next is a newer test from a company called Impramed, and it's a chemosensitivity prediction model. So they take the lymphoma cells from the lymph node. They run both flow and PAR, and they use all the data from the flow and the PAR to put into an artificial intelligence computer. And that computer uses the data from a high number of patients that were previously treated, looks at the characteristics of your patient's lymphoma cells, compares them to the others, and spits out a report that tells you which chemotherapies are likely to work for that particular patient. And they also have something called the CHOP prediction model, which tells you how likely is the CHOP protocol, which is our standard protocol for lymphoma, how likely is that going to work and for how long. So this is a relatively new test. We've been using it a bit over the past year or so, and I have sort of mixed feelings about it. I do think that it's helpful in some cases, but I'm not too sure how helpful it is yet. I think the more tests that are run, the more data they have to do the artificial intelligence, the better it will be. And they're already they just sent an email recently. They're on their 4th version of that artificial intelligence now. So I think the more information they get, the better this test will get, and maybe in the future might actually become something we run all the time. So I think it's good to know that that's out there, but it's not something we're doing quite a lot. All right, so moving on to staging. So lymphoma in dogs has 5 stages. 1 is a single lymph node, 2 is regional lymph nodes that don't cross the diaphragm, so either the cranial half or the caudal half. Stage 3 is all the lymph nodes on the outside of the body. 4 is the liver or spleen, and 5 is the bone marrow or blood or somewhere else that's not listed in the first 5. So you have to remember in dogs that the stages are not cumulative. So in other words, a dog can have stage 4 lymphoma and not be stage 1, 2, or 3. So they can have it in the liver or spleen and not in any lymph nodes. They can also have it in the blood or the bone marrow and not in any lymph nodes or the liver or spleen. So those are all possibilities as well. And that's the reason why we always talk about staging is not always that prognostic for dogs with lymphoma. It's more of just a descriptive staging system to kind of give you some idea of what's going on. But there's really not a huge difference in the different stages. There is also a substage. So substage A are dogs that are feeling well, and substage B are dogs that are having systemic signs, so they're clinically ill from their lymphoma. That is something that's prognostic, and we'll talk a little bit more about that. So the recommended staging for dogs with lymphoma is your minimum database of blood work, chest x-rays, abdominal ultrasound with spleen and liver cytology, and bone marrow aspirate. But again, since those are not always the stage is not always prognostic, a lot of those tests we always give the clients the option of doing them or not. Certainly chest x-rays and ultrasound are helpful, especially in older dogs, to make sure that there's not some other concurrent problem that's going on that we need to know about to give chemotherapy, or that would limit the dog's quality of life or lifespan before we move forward with all the chemotherapy, but they're certainly not required tests. Things that really do affect the prognosis are the grade or the size of those cells and the markers we know we get back on flow cytometry. The immunophenotype, so the B versus the T cell. Historically, we always say that dogs with hypercalcemia or a mediastinomas have a more guarded prognosis, but the reason is that those dogs are likely to have T cell lymphoma. So I don't know that it's because they're hypercalcemic or because they have a mediastinomas. I think it's just because they're more likely to have T cell lymphoma. The response to treatment is a big prognostic factor. So the faster they go into remission, the longer they tend to stay in remission. The substage, which we just mentioned, so dogs that are still feeling good tend to have a better prognosis. And then pre-treatment with prednisone affects the prognosis. And I want to take a second to talk about that, because we see a lot of dogs that are diagnosed with lymphoma that are already taking prednisone by the time they get to us. And I think a common concern is that them being on prednisone is going to make it harder for us to do our diagnostics or staging. And it doesn't really do that. It can, certainly, if the prednisone puts the dog all the way into remission, then it will be harder to do those diagnostics. But the more important reason is that prednisone does cause a more guarded prognosis. Prednisone induces the multi-drug resistance gene in lymphoma cells, and that makes the lymphoma cells more resistant to chemotherapy. So a dog that's feeling perfectly fine and has a diagnosis of lymphoma does not need to go on prednisone before they start chemotherapy, because it can actually make the chemotherapy less effective. A dog that is sick or not feeling well, those dogs do need to go on prednisone because we need to make them feel better quickly. But then we try to get the chemo going as quickly as possible to minimize the risk of causing that multi-drug resistance. So really, our recommended staging, again, baseline CBC biochem UA, and then immunophenotype. The chest x-rays, ultrasound, and bone marrow really depend on the patient, the client, and the results of those other tests. Those are sort of optional tests. All right, so chemotherapy and prognosis. So chemotherapy, I think hopefully we all know, is very well tolerated in animals. Side effects are common, but they're very mild and self-limiting, or at least acceptable to the client. You know, we use the same drugs as are used in people, we just dose them differently, and the protocol is different. In lymphoma, we tend to lean towards combination protocols. So protocols that include multiple different chemotherapies. So we have all these crazy names like LAP and CHOP and MOP and all this stuff, but they're just multiple chemos that sort of work together to fight the lymphoma in different ways. And they're more intense, dose-intense protocols. So dose intensity means how much chemo can you fit into a certain period of time. And the more chemo you can fit, the better the outcome tends to be for lymphoma. CHOP is our pretty standard chemotherapy protocol for dogs with lymphoma. And there's a lot of variations. Everybody kind of likes to do it a different way. One of my mentors, who also was Dr. Correa's mentor, she used to say that it's like a chili recipe. Like, everybody knows how to make chili, but it's always a little bit different just depending on how you were taught to do it. So I think that applies. Again, there are lots of different ways we can treat lymphoma, all chemotherapy-based: CHOP, adriamycin, lomustine, prednisone, L-SPAR. Then we have MOP and MOMP and LOP and all these crazy names. But in general, they all work. They just work for different amounts of time. It tends to be the rule. And you can see, if you look at this slide, at the top is our CHOP protocol, and that's where we have the highest response rates and the longest median survival times there. I want to talk a little bit about Tanovea. I talked about Tanovea last year, and Tanovea was conditionally approved at that time, and now it is fully approved for dogs with lymphoma in the United States. There have been a number of studies, and there are more than these 4 now, looking at it as a frontline drug, alternating it with adriamycin as a rescue chemotherapy, one with Tanovea and L-asparaginase together. So it is becoming a very commonly used chemotherapy now. I was a little scared of it at the beginning, but not so much anymore, and we use it quite a bit. It's given once every 3 weeks. Can be used as a frontline or rescue. Side effects are common, but they're the same as everything else. So decreased appetite, GI side effects, that thing. There are 2 side effects of Tanovea that are not common to other chemotherapies that we use in animals. One is the dermatologic side effects. So that's going to look like redness and irritation and sometimes ulceration of the skin in the axilla, inguinal area, sometimes perianal area, and definitely in the ears. So I see a lot of dogs that are on Tanovea and then give them a dose, they come back in 3 weeks, and now they have an ear infection and they're on medications. And that's probably because the Tanovea caused some side effects in their ear, and now they have an ear infection because of that. It's not a high percent, but it definitely happens. And then the other one is pulmonary fibrosis. So pulmonary fibrosis is scar tissue in the lungs, and that is generally considered a uniformly fatal side effect of Tanovea, but it's a very low percent of cases. It's reported as 4% in most of the trials, but it does seem to be, and this is totally anecdotal, but it does seem to be altitude dependent. So a lot of the trials were done at CSU, and those dogs at CSU had the highest incidence of pulmonary fibrosis. And the dogs that were treated with Tenobia in lower elevation areas, like on the East Coast, those dogs had a much lower incidence of pulmonary fibrosis. I've only had one dog with pulmonary fibrosis so far. So I don't think it's as common as the 4%, but it certainly is a possibility that they could develop that. I think at Animal Cancer Care Clinic, the most common way we're using Tenobia is the rescue after a doxorubicin-based protocol. So once they've had their CHOP protocol and they've come out of remission, then that's typically where we're using it. But obviously some variation. The overall response rate is 74%. So that includes complete response, partial response, and stable disease. And it works an average of 172 days, so about 6.5 months. Those with a complete response, it works longer. So same as we talked about response to treatment, the better it works, the longer it tends to work. And that's kind of a general rule with lymphoma drugs. It has changed to where prednisone is generally recommended at the same time as Tenobia. It doesn't take very much, a pretty low dose, but it seems to, again, anecdotally lower the risk of the skin side effects and the pulmonary fibrosis. And we're finding a lot of dogs need to be on an appetite stimulant as well to help keep their appetite up while they're taking Tenobia. Laverdia is a newer drug for lymphoma as well. Last year at this time, I just sort of mentioned it, that it was coming, and now it's available. It is an oral, it's the first oral treatment conditionally approved for dogs with lymphoma. So it's a tablet that's given twice a week at home. And then I have some data on how well it works. So it was looked at in a phase 1 and phase 2 trial so far. The phase 2 trial, the overall response rate was 37%, so not very high. But they saw clinical benefit in about 50% of dogs. The median time to progression was 29 days. And if you look at the percent of dogs that are the different patients, so naive patients, so patients who had never had any treatment, the median time to progression was 43 days, so longer than dogs that had relapsed. And dogs that had T-cell lymphoma tended to have a little bit longer median time to progression, which was also 43 days. So it is certainly being marketed for clients who don't want referral to oncologists because it's easy to do. You just give them the pills, they take them at home, you see them regularly for rechecks and blood work, and it doesn't have a lot of side effects. I think that now that we've been using it for some time, I think it has more side effects than they are marketing it, but they're easily controllable. So in other words, a lot of dogs get nausea, but if you just give them an anti-nausea before you give the Laverdia, that seems to help, and they can do pretty well on it. I think where we're using it a lot is in other situations. So once we've used other chemos, or the dog is in partial remission or complete remission after chemo, and we need some sort of maintenance type of therapy, that seems to be good use for it. And I think Laverdia and Tenobia has sort of changed the way that we think about lymphoma a little bit, because we're always focused on getting the dog into remission, remission, remission. We want those lymph nodes to be normal. And I think Laverdia and Tenobia have taught us that they don't necessarily have to be normal, like the lymph nodes don't have to be normal and the dog in complete remission. These drugs a lot of times get patients into partial remission or have stable disease, but they still feel good. And that's really the key in lymphoma, is that the dog feels good. And so as long as we're keeping the disease from progressing and the patient still has a good quality of life, you're accomplishing the same thing as getting them all the way into remission. It just probably isn't going to work for as long, but for a lot of people, that's totally okay. So this kind of concept of stable disease with lymphoma is a little bit new. It's definitely not what I was taught as a baby oncologist, but I think something we're starting to realize is an important way to look at lymphoma. Now, not to say we're not doing the typical chemo, like CHOP is still the way to go. We still want to get them into remission, but realizing at some point that's not going to be possible anymore, then we sort of say, okay, well, stable disease is okay. So there are certainly some less common types of lymphoma. Indolent lymphoma, I think, is something that's becoming more and more recognized simply because of things like flow cytometry. So indolent lymphoma is a type of slowly progressive lymphoma. So these are the ones that the patient's lymph nodes are a little bit big, and they're big for a long time, but they never get bigger, and they feel fine. And those are the ones, again, that you're going to do cytology and a lot of times get lymphoid hyperplasia, but it's really something else. And these, a lot of times, we don't necessarily treat them right away. So good examples are T-zone lymphoma, marginal zone lymphoma, chronic leukemia. So those dogs may have big lymph nodes. It may be in their spleen. It might be in their circulation. So they have mildly elevated lymphocyte count, but they feel fine. So a lot of those patients will just monitor. We just watch them for some period of time and see, is it progressing or not? And if it's not, then we don't do anything. And once it starts to progress, or the patient is feeling badly, or something changes on their blood work that's concerning, then we'll start treating. And a lot of them actually respond to chlorambucil and prednisone. So just easy low-dose oral chemo that they can do at home. Other lymphomas we do see in dogs are cutaneous or epitheliotropic. This tends to be a bit more aggressive with a more guarded prognosis, just because the chemo works really well, but it seems to lose effectiveness pretty quickly. Lomustine or CCNU is still our first-line treatment for cutaneous lymphoma, but now we know that Tenovia also works well for cutaneous lymphoma. There is a paper published using it as a rescue after lomustine in dogs with epitheliotropic lymphoma. In both of these drugs, the reason we choose them is they actually concentrate in the skin or the subcutaneous tissue, so that's the area of concern. Alimentary lymphoma or GI lymphoma in dogs is almost always high grade and also has a more guarded prognosis. Again, just because the chemo works, but it just seems to not work for very long. We tend to use CHOP or lomustine, or incorporate lomustine into the CHOP protocol or some sort of variation of that, because that seems to work the best. But it is definitely something we see periodically. There are also some less common treatments besides chemotherapy that we can use for dogs with lymphoma. So for example, radiation therapy can be included. The reason, I get this question a lot, why don't we take the lymph nodes out? And the reason is because lymphoma is considered a systemic disease. So even if all the lymph nodes aren't big, we sort of assume the lymphoma is kind of everywhere. And so if we're going to use a localized therapy like radiation therapy, we need to treat the whole body. Obviously, whole body radiation is fatal, and so you basically do half at a time. So you give a little bit of chemotherapy, try to get them into remission, irradiate half of the body, give a little more chemotherapy, irradiate the other half of the body, and then finish the chemo. And there's a couple of papers that show a longer prognosis with that type of treatment. The downsides to half body radiation is that it's more expensive, obviously, and it's a lot harder to get the patient through because you're irradiating all of the bone marrow. And so you tend to get a lot of issues with keeping the blood counts up and the platelet counts and being able to get the chemo. And so a lot of times the chemo protocols last a lot longer, and the patients, it takes a lot longer to get everything done. Also, half body radiation doesn't benefit every patient. There is a subset of patients that will live for an extended period of time with this type of treatment, but it's not all of them. So it is something we offer, but not something we do commonly. Bone marrow transplant is something that is done commonly in people when they have lymphoma that's not cured by chemotherapy. And so that is able to be done in dogs. It's quite complicated, and they do have a fair chance of mortality from that procedure. They have to stay in the hospital for several weeks. But the benefit is there's a chance of a cure, because there are some dogs that are cured by bone marrow transplant, and so that's the main reason to do it. And then the last is T-cell therapy. So there's a couple of groups out there doing T-cell therapy where they harvest T-cells from the patient and grow those cells out and teach them how to kill lymphoma cells and then give them back. And so that's something that's kind of gaining favor right now as well. It does seem to work, at least in the dogs that it's been done, but it's a bit complicated to do. I think that is something that's going to become more commonplace in the future, but right now is not very common. All right, I'm going to do a little bit about kitties. So in cats, lymphoma is usually GI related in most of the cats. We are all taught as veterinarians that young cats get mediastinal lymphoma and old cats get GI lymphoma. That's still the case, but we don't see many young cats with mediastinal lymphoma anymore, just because there's less of the retroviruses that cats get that cause that form. So the majority of cats are going to be older cats with GI lymphoma. They do sometimes get the same multicentric form that dogs get with big lymph nodes, but it's really uncommon. The biggest thing in cats is whether they have small cell lymphoma or large cell lymphoma. Small cell lymphoma is, I think, a little bit more common, although they're probably split down the middle, to be honest. It is more indolent in nature. In other words, it's kind of like the indolent lymphomas in dogs where it's very slowly progressive. We tend to treat it with chlorambucil and prednisone. Most cats do well. The response rates are very high, 80 to 90%, and usually they live over a year. And I think a lot of time for several years is what we see most of the time. Large cell GI lymphoma in cats, we do see it is more aggressive. It comes on very quickly. Those cats are going to be very sick all of a sudden. And we tend to use the CHOP-based chemotherapy that's used in dogs. But I think lomustine is a very reasonable option as well. Lomustine in cats only has to be given every 3 or 4 weeks. So it's a very attractive option for cats just because they don't travel as well sometimes and are a little bit hard to manage. But I think the CHOP is still kind of the standard of care for large cell in cats. And they kind of fall out into 3 response groups. There's one group where it doesn't work. So it doesn't matter what chemo you're going to give. Their lymphoma is already chemo resistant and it just doesn't help them. And then there's one group that's going to respond really well. They go into remission right away, and those cats live for a long time, like 1 to 2 years. That's not very many of them. That's maybe 10 to 20% of the time, but it definitely happens. And then there's kind of all the cats in the middle where they're going to respond. It takes a few weeks to get them feeling better, but they do. And then they're going to live somewhere between about 8 to 10 months as average. For GI lymphoma in cats, we tend to save surgery when there's an obstruction or if we're having trouble getting a diagnosis. So again, even if there's like a big mass in the abdomen, as long as it's not causing any sort of intestinal obstruction, we don't necessarily go straight to surgery. There is a paper that came out not too long ago that said maybe it is beneficial for cats to have that mass removed before chemotherapy, but that they still need chemotherapy. But traditionally, we don't do that very frequently. There are not really any good prognostic indicators for cats. The biggest one is response to treatment. So if it works, that's better than if it doesn't work. And then their retrovirus status does play a role as well. There are some species differences. So there are different drugs that we use in cats that we don't, that we use in dogs that we don't use in cats. We dose them differently. The toxicities are different. So for example, adriamycin is cardiotoxic in dogs, but it's renal toxic in cats. So kind of knowing all of those things is helpful. And then there's some anatomic differences in cats. So for example, cats get renal lymphoma much more commonly than dogs. Renal lymphoma in cats tends to be a very aggressive type of cancer, and it's not very responsive to treatment. And then they can get nasal lymphoma much more commonly than dogs, and that tends to be a much less aggressive form of lymphoma in cats. So they tend to do very well with nasal lymphoma. And then just some clinical pearls. So we always kind of like to summarize everything. So lymphoma is a catch-all term for about 24 types of cancer in dogs and cats. We talked about, different grades of cancer, indolent versus others. Most are going to be intermediate to high grade, but there are some indolent lymphomas in dogs, and those are becoming more and more recognized, I think. In dogs, the peripheral lymph nodes are the most common site. In cats, the GI is the most common site. Cytology is a good first screening test for lymph nodes. There are a lot of different treatment protocols we can pick from. Most are CHOP-based. That gives us the best results, but there are a lot of others. We always spend a lot of time going through clients and explaining, this is the best, but if you take all of these other factors into consideration, these are all of your options, and figure out which one is going to work the best for their pet and their family. Lymphoma is initially very gratifying to treat because it has a very high response rate and durable responses, but cures are rare, and it's generally a fatal cancer. And the indolent subtypes, again, still generally fatal, but they can live for many years. All right, and I'm happy to answer any questions.
Dr. Soanes, thank you so much. So informative, so interesting. Of course, We all love to talk about lymphoma. And so, yes,
Mhm.
thank you. So, got a couple of questions for you. All right, let's start with, what is the best way to submit a lymph node sample in suspension for flow cytometry?
Oh, that's a good question. I think it's always helpful to call the lab to make sure, but the kind of general method is that you get a 6 ml syringe with a 20 or 22 gauge needle. You put 1 ml of sterile saline in the syringe, and then you aspirate the lymph node. So put the needle in, pull back on your syringe, and kind of move the needle, the woodpecker technique, they call it. And you want to see those cells come into the fluid. So you want to see the, like, almost like little worms of lymphocytes come in, because you need quite a lot of cells. And then you want to put that into an empty tube. So now I think they're white top tubes that are empty. And then you add 0.1 mLs of saline. So, of serum from the patient. So 1 ml of saline to take your sample, and 0.1 mLs of serum to the cells to keep them alive. And then that's how you would submit it. And generally it's going to go overnight on ice if you're sending it like to Colorado like we do, or obviously IDEX and Antec will pick it up quickly.
Great. Okay, thank you. Good explanation. So here's another one for you. What is the difference between lymphoma and lymphosarcoma?
I think it's just a terminology to me. I think lymphoma is a bad term, because technically lymphoma by definition means it's benign, but it's never benign. So I think it truly is lymphosarcoma, but we just kind of call it lymphoma as a nickname. At least that's what I know.
I agree. I think it's just a terminology issue, and they're the same thing. Okay, how about lymphoma in the central nervous system? Can you comment a little bit about that as far as prognosis, treatment?
Yeah, that's a good question. I never include that one for some reason, because to me it's very rare to see that, but we do see it from time to time. It's a little harder to treat because a lot of the chemotherapy drugs don't cross the blood-brain barrier. We know that. And so you have to sort of choose, or at least include, chemotherapies that do cross the blood-brain barrier to make sure that you're getting them to where the lymphoma is. The other thing that's helpful for CNS lymphoma is actually radiation. So you can actually irradiate parts of the brain and spinal cord at certain doses and dose rates and all these things that prevent a lot of side effects, but that work well for the lymphoma. And then you kind of avoid the rest of the body in that. And then if you're really brave, you can actually inject the chemo into the CSF fluid and treat the lymphoma that way. It is a little bit harder to treat, I think. It's harder to manage the patients because they're often, having a lot of neurologic signs, and the clients don't manage that very well sometimes. And I think their prognosis is very variable, because if you're aggressive with the treatment, they can still do well. But I think in a lot of cases, they don't, just because we're not able to be as aggressive with the treatment as we would like to. And then interestingly, I mentioned cats with renal lymphoma. So a very high percent of cats with renal lymphoma will develop CNS involvement with that lymphoma as well. So that's something we kind of want people to watch out.
Great. Thank you. Good information. Thank you. Here's one. Here's a tricky one. What is the best way to diagnose GI lymphoma versus IBD?
That's tricky. In cats, I'm guessing, yes.
In cats.
So actually, at ACVM, they're writing a consensus statement on that to try to guide us in differentiating inflammation in the GI tract versus lymphoma. I think that full thickness biopsy is still the gold standard, of course. But I think endoscopic biopsy is really helpful. And I think sometimes even cytology of the intestinal wall is helpful. And I think those two are more helpful now because we have tests like PAR. So that's a really good example of when PAR is helpful. So you say you get a cytology of the intestine or an endoscopic biopsy, and it's inconclusive, then PAR, the PCR for antigen receptor rearrangement, can be run on those samples because the DNA is still there, and that will tell you if they're clonal or not. And if there's that clonal population, it points us towards lymphoma. So I think we've always said biopsy is the gold standard, still is, but I think endoscopy and cytology are more helpful now that we have PAR.
Yeah, I would agree. I feel like now we get a lot of diagnoses in feline patients from PAR and flow, whereas before we were looking at sending him to surgery sometimes, to actually get a diagnosis. And you always hate to do that when the surgery is purely for diagnostic purposes and not for treatment purposes. So yeah, I would agree. Flow and PAR have really helped us a lot, particularly in those feline GI lymphomas. So let's see, here's one. Here's a tricky one. If you have a client who refuses oncology referral or treatment, will prednisone be an effective palliative treatment for quality of life? And if so, how long?
Oh, for sure. That's a very good question. So yes, if they don't want referral, or even when we see them and they've declined the treatments, we put them on prednisone. It almost always works for lymphoma. And the average, I would say, is 1 to 3 months. I think that's what, it's funny because no one's ever done a study on it, but one actually came out in the last year looking at prednisone as the only treatment for dogs with lymphoma. And I think the median survival time was like 2 months or something like that, which is what we usually say, kind of in that 1 to 3 months range. They do have to stay on the prednisone indefinitely. You can taper the dose down to manage the side effects. And of course, we always tell people, that's a very reasonable thing to do for your pet. Just want to make sure you know that if they're on prednisone for long enough and you change your mind and you want to do the chemo, it may not work as well in the future, but definitely prednisone as palliative care for sure.
So thank you. I do want you to know that I am getting quite a few comments on the great Dachshund group photo. So everybody is really liking that picture. So that's good. I've got one more that came up. Okay, it has to do with tolerance and chemo. How do we really know that our patients are actually tolerating the chemo when compared to what you hear about in people?
How do we know that? Clients ask that from time to time too. I guess we don't, right? Because they can't tell us, but I think you can get a very good idea of how your pet feels. I mean, you're with them every day and you know their typical behaviors and their routines and what they usually do. And I think you can tell if they feel okay or not. I'm sure they do have more side effects and feel from time to time not as well as we think they do. But that's why I kind of mentioned when I was talking about that part, in parentheses I wrote, or at least acceptable. You know what I mean? Like maybe they're not feeling as great as we think they are, but we feel like it's acceptable for the benefit that we're giving them in the long term. So that's a really good question. I don't know that I can fully answer it, but I do think that people can tell. Like I can tell if my dogs feel okay. The smallest thing changes and I can notice that whether I realize it or not. So I think you can get a good idea.
Yeah, and I think like you mentioned before too, our protocols are really different. Although we may use the same drugs that are used for people, our protocols are different. The doses are different. The frequency of administration is different. I really do think our dogs have, and cats, a lot less side effects than people. And I've always thought about this over the years. I also think that there is, like, our dogs don't know they have cancer. Our patients, our cats, they don't know. And so they don't know they're getting chemotherapy. So I wonder if that's part of it too. I don't know. So I'm not seeing, let's see, just going to make sure. All right. So I'm not seeing any more questions right now. So I want to thank you, Dr. Soanes, for providing us with such good information, talking to us. It was really great. Thank you so much. Thank you, everybody, for coming, for joining us. You will be getting an email with your CE certificate. So you'll see that in a couple of days. Okay, so look for that. And remember that on August 25th, we'll be here again with you. We'll do our next summer webinar series, number 3. We'll be talking about transitional cell carcinoma. And then again in September, we'll do our final webinar presentation, and that'll be on radiation therapy with Dr. Lyons, our radiation oncologist. So thank you all. Have a wonderful evening and a wonderful Friday tomorrow, and take care. Be well.